Dear colleagues, welcome to the 4th annual OncoAlert Colloquium presented by the OncoAlert Network and our esteemed partners at the American Society for Radiation Oncology, the European Society of Surgical Oncology, the European Society of Gynecological Oncology, MASC, the International Association of Supportive Care in Cancer, SIOG, the International Society for Geriatric Oncology, and OncoAlert Consortium, which is made up of 12 medical oncology societies from low and middle income countries. Together, we bring you this end of the year review for 2023 in oncology. I'm Gilbert Morgan, clinical oncologist by training and director of the OncoAlert Network. The Colloquium, unfolding from February 5th to the 10th of 2024, offers an end of the year review showcasing the most impactful findings in oncology in 2023. Our program is meticulously crafted with presentations divided by tumor type and delivered by handpicked faculty of world-renowned medical, surgical, and radiation oncologists, urologists, and most importantly, patient advocates. As with all other OncoAlert colloquiums, this 4th colloquium is realized without any financial support. All presentations throughout the week are freely accessible, and we encourage our colleagues to share the colloquium links with everyone in cancer care and help us surpass last year's colloquium numbers, which had over 12,000 viewers worldwide in less than 6 months. Today, we bring you the top in GU Oncology 2023, including the latest updates. Presentation are as follows. Dr. Gil Morgan with FDA approvals in GU Oncology for 2023, Dr. Toni Choueiri with the best of kidney cancer in 2023, Dr.Andrea Apolo with the best of bladder cancer 2023, Dr. Neeraj Agarwal with the best of prostate cancer in 2023, and Dr. Axel Merseburger with the top in urology for 2023. We then finish it off with Dr. Sophia Kamran in the ASTRO session on the best of GU radiation oncology for 2023. So now, without further delay, FDA approvals in GU oncology. Dear colleagues, this is Gil Morgan, OncoAlert Director, and a great pleasure to kick off this colloquium with the most practice changing in oncology, and nothing says practice changing more than an FDA approval. So here you have it, colleagues, the top FDA approvals in GU oncology for 2023. In April, the FDA granted accelerated approval to enfortumab vedotin in combination with pembrolizumab for patients diagnosed with locally advanced or metastatic urothelial carcinoma or ineligible for cisplatin-containing chemotherapy. The approval was based on findings from the EV-103 KEYNOTE-869 study, comprising a dose escalation cohort, cohort A and cohort K, where patients received enfortumab vedotin plus pembrolizumab. Among 121 patients, the confirmed objective response rate was 68%, with 12% achieving complete responses. Median duration of responses ranged from 22 months to not reached. In May 2023, we saw the approval of an F18 injection, marking a significant milestone as the first radiohybrid PSMA-targeted PET imaging agent approved for prostate cancer. This imaging agent is designed to detect PSMA-positive lesions in patients with prostate cancer suspected of metastasis eligible for initial definitive therapy, or those who suspected recurrence based on elevated serum prostate-specific antigen levels. Results from the Lighthouse and Spotlight trials showcase the ability of F18 injections to accurately identify distant metastatic lesions, thereby enhancing disease staging in recurrent prostate cancer. The correct detection rate, ranging between 45% and 47%, underscores its clinical significance by indicating the percentages of patients with at least one true positive PET finding compared to the standard of truth of histopathology and confirmatory conventional imaging. Also in May 2023, the FDA sanctioned olaparib in combination with abiraterone and prednisone for adult patients diagnosed with deleterious or suspected deleterious BRCA-mutated metastatic castration-resistant prostate cancer confirmed by an FDA-approved companion diagnostic test. The approval stemmed from the PROPEL trial encompassing 796 patients with metastatic castration-resistant prostate cancer randomized to receive either olaparib with abiraterone or placebo with abiraterone, in addition to prednisone and prednisolone. Notably, patients with prior systemic therapy for metastatic castration-resistant prostate cancer were excluded, while those with prior docetaxel for metastatic hormone-sensitive prostate cancer were allowed. A statistically significant improvement in radiological progression-free survival was noted in the olaparib with abiraterone group compared to the placebo with abiraterone cohort, particularly in the subset of patients with metastatic BRCA. In June 2023, talazoparib, the first PARP inhibitor approved alongside with standard of care therapy enzalutamide, gained FDA approval for treating adult patients with homologous recombination repair gene mutated metastatic castration-resistant prostate cancer. Supported by the findings from the phase 3 TALAPRO-2, the combination of talazoparib plus enzalutamide demonstrated significant improvements in their radiographic progression-free survival compared to placebo plus enzalutamide, particularly in patients with HRR gene-altered disease. Notably, patients with BRCA mutations also experienced significant benefits. Additionally, the combination therapy prolonged time to PSA progression and time to cytotoxic chemotherapy with a favorable objective response rate. In August, the FDA's approval of the combination tablet of niraparib and abiraterone acetate with prednisone represented a significant breakthrough as a first-ever dual-action tablet for treating BRCA-positive metastatic castration-resistant prostate cancer. The decision stems from the phase 3 MAGNITUDE study involving 765 patients with metastatic prostate cancer, where the combination significantly reduced the risk of radiographic disease progression or death by 47% compared to the placebo combination. Notably, in patients with BRCA-positive disease, the median progression-free survival nearly doubled with niraparib abiraterone acetate combination compared to the placebo. The safety profile of the combination was consistent with individual drugs, albeit patients discontinued treatment due to adverse events. And finally, in November 2023, we saw the FDA approval of enzalutamide for non-metastatic castration-sensitive prostate cancer with biochemical recurrence at high risk for metastasis, marking the first and only androgen receptor signaling inhibitor to receive FDA approval in this population. The approval is backed by data from the phase 3 EMBARK trial, where the enzalutamide plus androgen deprivation therapy leuprolide reduced the risk of metastasis or death by 58% compared to leuprolide alone. At a median follow-up of 60.7 months, the combination demonstrated a remarkable improvement in metastasis-free survival rates compared to placebo, with an overall favorable safety profile. And there you have it, folks. That's a year in GU oncology approvals by the FDA. Now on to the colloquium.
Yeah, hi, hello, my name is Toni Choueiri from the Dana-Farber Cancer Institute in Boston. My pleasure here to be part of the OncoAlert Colloquium, to tell you a bit what happened in kidney cancer specifically in 2023. This is not an exhaustive list, but these are the, flagship, if you want, trials that led to important answers in the field. Some are practice changing and others are practice informing. So let us start by the list. I picked 5 important trials here. Some of them are just updates and others are completely new. We start by CONTACT-3. CONTACT-3, why it's important. CONTACT-3 is a study that goes beyond kidney cancer. It's the first trial that tests immune checkpoint inhibitors, here PD-L1, re-challenge after progression on prior ICI in any cancer type. This is the only randomized phase 3 trial and happened in kidney cancer. So patient with metastatic clear cell renal cell cancer or some non-clear cell renal cell cancer who experience progression of their tumor after immune checkpoint blocker, with the immune checkpoint blocker here, a PD-1 or a PD-L1 inhibitor, being the immediately preceding line of therapy. These patients were randomized to a TKI, a standard TKI cabozantinib, or the same plus atezolizumab. In practice, we see in kidney cancer and as well as other tumors, some of the practice continue the immune checkpoint inhibitor on board while switching other therapy or re-challenge even after disease progression. And the progression-free survival here, which was one of the two primary endpoints, was completely negative, hazard ratio 1.03, and the overall survival was also completely negative. I don't show you here the forest plot, but there was no major signal favoring the atezo-cabo group. I think this is an important information to the field. And renal cell cancer, again, is leading here the charge with another trial that finished actually accrual, a trial by the name TNIVO2, which is very similar in terms of principle of a TKI versus TKI plus IO, while here the checkpoint inhibitor is nivolumab. So it's not atezolizumab, the PD-L1 inhibitor, but it's nivolumab, that PD-1 inhibitor. It's only clear cell renal cell cancer with an immediate preceding therapy being the PD-1 or the PD-L1 inhibitor. Smaller phase 3 trial where patient experimental arm is nivo-tivo, nivolumab, tivozanib, or tivozanib at a lower dose. There's a mistake here. The tivozanib dose is 0.89 milligram. By the way, that's an earlier design, so it's a lower dose because of the hypertension when combined with nivolumab. Study finished enrollment and is expected hopefully 2024 or 2025. Keynote 564, I think the major update, the study has been presented in 2021 as part of the plenary session at ASTRO, but the important thing here is this news release that happened earlier in 2023 about pembrolizumab extending overall survival, which is the first ever overall survival benefit in any adjuvant therapy of kidney cancer and in any adjuvant PD-1 based therapy in solid tumors. Overall, again, this is the design. High-risk clear cell renal cell cancer, get 1 year of pembrolizumab versus placebo, disease-free survival per investigator primary endpoint. And this was the most updated disease-free survival from the paper in Last Oncology, actually published in 2022. And the hazard ratio was 0.63. And now the overall survival at that time was not mature, despite you see here has a ratio of 0.52 and a 95 confidence interval that do not cross 1, but that's only 33% of event. But now we have the overall survival benefit. So this is going to be presented at the GU ASCO symposium, and probably if you're listening to this and the GU ASCO symposium in San Francisco happened, then you know the result. January 25 to 27 at in San Francisco. Belzutifan is a new drug that just now, as I speak, just approved in kidney cancer in metastatic clear cell RCC. When I give you some updates and some new data, it's a new target. It's HIF2. It's a transcription factor, which is small molecule by the name belzutifan target. This is a review article. Now it's 3 years ago that we did with Dr. Kalin, who received the Nobel Prize in 2019 based on his work along that axis and how it applies to oncology, the VEGF, HIF2 axis. Again, very hard to target in the past, that transcription factor, because transcription factor, you know, they don't work, like they're not cell surface, you know, target. But belzutifan actually is able to go to a specific domain in HIF2 and inhibit HIF2. And we had earlier result already published about the activity. And now this is the phase 3 trial, which our team was part of in post PD-1 and VEGF inhibitor. Again, clear cell renal cell cancer, up to 3 prior line of therapies get randomized to belzutifan or everolimus as a control here, but patients need to have had their tumor experiencing progression on PD-1 and VEGF therapy. The study here endpoint, primary endpoint is PFS, and despite the similar median, you look at the curve actually after 6 months separated, and the hazard ratio is 0.75, so 25% decrease in the risk of progression or death, and maintain the same with interim analysis too. Overall survival, another endpoint, primary endpoint, was not met despite the numerical difference of 3 months, 3 to 4 months between both arms. It actually was not met, 0.87, but there was no detriment here. There's a separation of the curve that start probably after a year, but doesn't lead to statistical significant. Response rate mirrored the earlier experience with belzutifan, 22 versus 3.5% here overall. And important thing to mention that the CR rate, the complete responses rate, were higher also with belzutifan. And you know, after the presentation, December 14th, so before the end of the year, the FDA approved that agent. So now next step is, of course, combining it. And this is the result of the combination, also presented at ESMO 23. This was presented prior, but this is, if you want, one of the updates that included the 2 cohort of the combination of belzutifan with cabozantinib. In green, untreated patient, cohort 2, prior immunotherapy. And as you can see here, cohort 1 response rate, untreated patient, no prior line of therapy, 70%. 70% overall response rate in patient. Almost, I mean, everyone had the tumor shrinkage. Even the patient with PD was actually responding except for a new lesion. And the median duration of response was over 2 years. In cohort 2 also, there is activity, 31% response rate with 88% of patients with available post-baseline scan has a reduction in tumor burden. And again, the duration of response, 31 months. So this is active. PFS, single arm, be careful, but still 30 months in prior in untreated patient and close to 14 months in previously treated patient. And the survival here, you know, in untreated patient and previously treated patient is something to be noted. And Dr. Agarwal here presented actually, again, during ESMO 2023, LightSpark 013 around belzutifan. But here the question is the dose that actually was approved December 14 of 120 milligram enough? Could we go up on the dose here with 200 milligram and get more efficacy perhaps? So that was what LightSpark 013 tried to ask. And the answer is no. The progression-free survival is not different. Look at the hazard ratio for PFS and OS. There is no difference between, you know, 220. Just to remind you also, this is patients whose tumor received prior line of therapy and had progression up to 3 prior lines. So there is no difference. But if anything, although this is just numerical difference, the dose modifications that occurred on the 200 milligram and the toxicity that led to treatment discontinuation seem higher on the higher dose overall, as well as the dose reduction, the dose interruption. And some of the treatment-related adverse event led to treatment discontinuation, 9% on the higher dose compared to 2.6%. So the 120 milligram dose is good. Rhinotorch, also presented at ESMO 23, was a very important study, at least globally, because it's the first ICI-VEGF combination in China. Think about pembro-axi combo, but replace the pembrolizumab by toripalimab. So untreated patient that actually were of clear cell histology, though here they needed to be intermediate or poor risk by IMDC criteria. That was the stratification. So here, the study exclusively conducted in China, randomized patient to sunitinib at full dose versus toripalimab plus axitinib, primary endpoint PFS, and it was met. 18 versus 9.8 months, favoring the combination with a hazard ratio of 0.65. This is not a surprise. Overall survival, quite intriguing and promising. We can't call it significant because there was no formal testing for OS because the number of deaths needed to 204 were not achieved. Nevertheless, the curve in blue of the combination is on top. This is kind of very promising. And finally, important for the field kidney cancer is the ZIRCON study, which dealt with antibody-based PET imaging targeting really here a clear cell RCC, important target, which is CA9, using this zirconium girentuximab. So the girentuximab is an IgG1 kappa light chain monoclonal antibody. Think about it as an anti-CA9 that binds to CA9 and specifically on clear cell RCC and is internalized. And there has been, safety experience in the past with it. Interesting thing, it has a hepatobiliary rather than a renal excretion, so it can you can visualize the kidney better. Now the payload is what? In order to see the positron emitter, it's zirconium-89, which has a half-life or 3 days, which also is hepatically clear. Previous study before this showed at least safety and specificity to tumor, and administration is usually up to 1 week, 4 to 7 days. After the administration, it's shown to be safe, and you can look at the imaging at the PET-CT. So this is very interesting, and this is the most important, one of the most important slides here of the analysis. The full analysis set 284 patients, and this is the sensitivity and the specificity by 3 independent reader, and it's all really close here. But the overall sensitivity, both are all sensitivity and specificity over 85%. So 85.5 sensitivity, specificity 87%. If this is positive, the positive predictive value is 93%. Now the negative predictive value is around 75%. Can do better here, but the overall accuracy is 86%. This seems to be superior to the CT scan overall. So there are some clear cell RC that don't light up, and there are some papillary RC that light up. This is why this is not 100%, but I think this is promising, and to me this is quite good, especially with the positive predictive value. This is an example. 1 centimeter, they went even to smaller masses. 1 centimeter renal lesion. They included here, even larger tumor, but this is 1 centimeter, 57. Active surveillance. Yes, no, maybe not an ideal candidate for surgery. Maybe patient doesn't want to have surgery. 1 centimeter kidney mass, and this is the ZIRCON study. Patient was on ZIRCON study and had the PET, which was clearly positive, highly likely, but ended up with partial nephrectomy, which showed clear cell RCC and confirmed by central pathology. Beautiful images here. That's all what I have for you here. I want to thank OncoAlert for having me part of this, and all the OncoAlert collaborators. Have a great day, and I hope you're already having a 2024 that started that is successful and healthy. Thank you.
Hi, Hi, I wanted to start off by thanking my good friend Gil Morgan for inviting me today to talk about best of bladder cancer updates for 2023. It has been quite a year for our patients with bladder cancer, with a lot new updates and a lot to talk about. I broke it down by first line, second line, muscle invasive and non-muscle invasive bladder cancer. The big outcome this year for December 2023, or for last year, I should say, was enfortumab vedotin plus pembrolizumab as first-line therapy for patients with metastatic urothelial carcinoma. And we'll go through the data for EV302. We'll also discuss the data of nivolumab plus gemcitabine and cisplatin. This is the 901 study. We'll talk about second-line approval of erdafitinib, how the label has changed a little bit since the update of the THOR study. We'll talk about muscle-invasive bladder cancer. I had the privilege to present the results of the Ambassador Phase 3 trial, so we'll discuss that today. And this is not really for 2023, but in December 2022, we did have the FDA approval of nadofaragene firadenovec, and we'll just discuss that and what the indication is for. So with that, we'll start off with first-line therapy for metastatic urothelial carcinoma. The standard of care before ESMO 2023, and this was in October, was platinum-based chemotherapy, and it's been platinum-based chemotherapy for years. And this is gemcitabine and cisplatin, dosed in MVAC, or patients that are cisplatin ineligible, carboplatin and gemcitabine. There is a small number of patients that can't get any kind of platinum, and those patients can be treated with pembrolizumab. If the patients respond, then they go on to maintenance therapy with avelumab or pembrolizumab. And if they don't respond, they still receive a checkpoint inhibitor in the second-line setting, pembrolizumab, nivolumab, or avelumab. And in the second-line and beyond setting, we had enfortumab vedotin, erdafitinib for patients that harbor an FGFR3 alteration, sacituzumab govitecan, second-line chemotherapy, or of course, a clinical trial. And enfortumab vedotin plus pembrolizumab did receive accelerated approval in April 2023, and that was based on results of cohort A and cohort K in cisplatin ineligible patients, but now it has full approval, and we'll discuss a little bit more about the EV302 data. So just to recap, enfortumab vedotin is an antibody-drug conjugate targeting Nectin-4. The payload is MMAE, and it has the linker that is stable in circulation but releases the cytotoxic agent in the target cell. So several phase 3 trials have tried to improve upon platinum-based chemotherapy by adding a checkpoint inhibitor either alone or in combination with chemotherapy. We have seen the results of the IMvigor130, the Keynote-361, and we are awaiting the results of the Nile study. I was really fortunate at ESMO 2023 to be the discussant for 2 positive phase 3 first-line trials, the Checkmate 901 study with nivolumab plus cisplatin and gemcitabine. I had multiple arms, but that's the one that was presented, and EV302, which was a randomized study of enfortumab vedotin plus pembrolizumab versus standard platinum-based chemotherapy. So the goals for treatment for first-line setting in urothelial carcinoma is early shrinkage, durable responses, longer overall survival, and minimal treatment toxicity. And for years, we have been using platinum-based chemotherapy. And if we look at the control arms, the platinum-based chemotherapy control arms from the trials that have recently been reported in patients with bladder cancer in the metastatic setting, including the IMvigor130, the Keynote-361, and the EV302, we see that the overall response rate ranges from about 44 to 45% for platinum-based chemotherapy. And if we only look at cisplatin, it's a little bit better. The cisplatin plus gemcitabine is about 43 to 50%. And if we look at carboplatin-based control arms, that's about 41 to 42%. The overall response rate for EV plus pembro is the highest that we have seen at 68% with 29% complete response. The overall response rate for nivolumab plus gemcitabine was also very good at 58% with 22% of patients having a complete response. But the overall response rate of EV plus pembro is higher. And when we look at all of the trials together, we see that the combination of EV plus pembro and the combination of nivolumab plus cisplatin and gemcitabine have higher overall response rate compared to platinum-based chemotherapy and other combinations. And when we look at the median duration of response, that was 9.5 months for the Checkmate 901 and not reached for EV302. So nivolumab plus cisplatin and gemcitabine improves survival over cisplatin and gemcitabine. And when we compare it to other combinations, it just looks, the median overall survival looks better with a median overall survival of 21.7 months. But when we dive a little bit deeper, these other studies had both carboplatin and cisplatin in it, and they were negative. They didn't meet their primary endpoint. But when we look at only the cisplatin-based combination arm, we see that the results are a little bit more comparable. In the median overall survival ranges from about 20 to 22 months with cisplatin-based chemotherapy combined with a checkpoint inhibitor, and that was with nivolumab, atezo in the IMvigor130, and pembrolizumab in the Keynote-361 study. But nivolumab plus cisplatin and gemcitabine has the best overall survival compared to all of them, met its primary endpoint, and it's the first chemo-IO combination to show a survival benefit in a phase 3 trial. But is it a new standard of care in metastatic urothelial carcinoma? What about the standard of care now, which is maintenance of avelumab? How does the Javelin Bladder 100 compare to the Checkmate 901 study? It's really difficult to compare these two studies because they're different. One of them used a checkpoint inhibitor in combination with chemotherapy and also gave a maintenance part of nivolumab. Also, there was a maintenance component to it. And the Javelin Bladder 100 only gave maintenance of avelumab, but only to the patients that responded. So it included only the patients that responded to chemotherapy. So again, different patient populations, so it's very difficult to compare. And when we do look at both of these trials together that were reported at the same time, the Checkmate 901 and the EV302, the combination of enfortumab vedotin plus pembrolizumab really has the best overall survival, with a median overall survival of 31.5 months versus 16.1 months, so doubling of the overall survival compared to what we saw with adding nivolumab plus cisplatin and gemcitabine, which was an overall survival of 22 months. And when we look at the control arm, we see, well, let's see how many patients received checkpoint inhibitor. More patients in the EV plus pembro control arm received a checkpoint inhibitor, either as maintenance or as subsequent therapy after they progressed. So EV plus pembro takes first place as the best first-line regimen for urothelial carcinoma. And it now has become a standard of care. Let's look a little bit at the other components of the EV302 study. So in addition to overall survival, we have an improvement in progression-free survival of 12 months. We have an overall response rate of 68%. And when we look at the, and this was very consistent with what we saw in cohort A and cohort K, although those were specifically for cisplatin ineligible patients, very similar in terms of the overall response rate. And when we look at the subgroups, in terms of which subgroups benefited, they all benefited with the combination of EV plus pembro, regardless of PD-L1 status, regardless of liver metastases, or cisplatin eligibility. And because of this overall survival benefit, really enfortumab vedotin is a new standard of care for patients with advanced metastatic urothelial carcinoma. So the standard of care has changed. This is really important. And the US FDA agrees with me. And in December 2023, gave full approval to the combination of enfortumab vedotin plus pembrolizumab in patients with metastatic urothelial carcinoma. Now things get a little bit complicated, because if this is the first line treatment for patients, then what then is the second line treatment for these patients? Is it now cisplatin or carboplatin, just platinum-based combination? And where do the other agents fit, like sacituzumab govitecan and erdafitinib? We need to design trials in order to answer these questions. Right now, we don't know what the best second-line treatment, what the toxicity is. Can we re-challenge with a checkpoint inhibitor? That really makes it complicated for the role of the nivolumab plus gemcitabine and cisplatin, because that is also using a checkpoint, and ED plus pembro uses a checkpoint. So is there a role for giving additional checkpoint after progression on ED plus pembro? These are questions we don't have answers to right now. So let's move on to second-line therapy and third-line therapy. We can start off with erdafitinib. Erdafitinib is a pan-FGFR tyrosine kinase inhibitor that received accelerated approval in April 2019 for platinum-refractory metastatic urothelial carcinoma patients that harbor FGFR3 alterations and have progression after first-line platinum-based chemotherapy. And it showed an overall response rate of 40%, progression-free survival of 5.5 months, and a median overall survival of 11.3 months in a single-arm phase 2 study of about 100 patients. And we were awaiting the results of the Thor study, and we have now seen the results of the Thor study, both for cohort 1 and cohort 2. And the Thor study is a randomized phase 3 trial of erdafitinib versus second-line chemotherapy or checkpoint inhibitor, depending on the prior therapy that the patients received. The first cohort randomized patients to receive erdafitinib versus chemotherapy, and we saw the results of this at ASCO 2023, and erdafitinib was superior. Now, remember, this is in patients that are FGFR3 positive. The median overall survival was 12 months versus 7.8 months for patients receiving second-line chemotherapy, and the overall response rate was 46% with erdafitinib and 11.5% with chemotherapy. Now, we saw the results of cohort 2, and this is erdafitinib randomized with pembrolizumab. So erdafitinib versus pembrolizumab in patients with metastatic urothelial carcinoma. We saw these results at ESMO 2023, and we were surprised because these are patients that are FGFR3 positive. We were surprised that the primary endpoint was not met. The median overall survival was 10.9 months for erdafitinib versus 11.1 months for pembrolizumab. So based on these outcomes, the US FDA has actually changed the label. Now erdafitinib has full approval for metastatic urothelial carcinoma patients that harbor FGFR3 alterations, but it is not recommended for the treatment of patients who are eligible for and have not yet received a checkpoint inhibitor. So I wanted to mention sacituzumab govitecan. This is an antibody drug conjugate targeting TROP2 with SN38 as the payload. It has been tested in bladder cancer in the metastatic setting in about 100 patients, showing an overall response rate of 27%. And currently it has accelerated approval for patients with metastatic urothelial carcinoma after platinum-based chemotherapy and after checkpoint inhibitor. And we are still awaiting the results of a confirmatory phase 3 trial of the TROPiCS-04. So we'll see what the results of that are. There have been other antibody drug conjugates too that have shown some very nice activity in patients with metastatic urothelial carcinoma. Disitamab vedotin is an antibody-drug conjugate targeting HER2, and it received a breakthrough therapy designation for bladder cancer in patients that were HER2 positive. A trial reported an overall response rate of 50%. So that was really, really interesting. And when it was combined with a checkpoint inhibitor, this is in metastatic bladder cancer patients that were HER2 positive, a small cohort of 40 patients, the overall response rate was 73%. So this is very promising. And there are several phase 3 trials that are ongoing right now looking at the combination of disitamab vedotin plus a checkpoint inhibitor versus chemotherapy in patients that are HER2 positive. And other antibody-drug conjugates targeting HER2 have also been tested in bladder cancer, including trastuzumab deruxtecan that was tested in the Destiny pan-tumor study, and the interim results have been reported in bladder cancer patients. Those are the bars in yellow. We saw a very nice overall response rate of about 40% in patients that were HER2 3+ up to 56%. So really great responses. These are the waterfall plots in yellow for bladder cancer patients. So again, another antibody-drug conjugate that is active in urothelial cancer patients. I now want to move on to neoadjuvant therapy for muscle-invasive urothelial carcinoma. For years, the standard of care has been platinum-based chemotherapy, either dose-dense NVAC or gemcitabine and cisplatin. We have seen the results of the VESPER study, and this is a randomized phase 3 trial of dose-dense NVAC for 6 cycles versus gemcitabine and cisplatin for 4 cycles. The outcomes of this have been reported with the primary endpoint of progression-free survival at 3 months, 3 years, being superior with dose-dense NVAC times 6 cycles versus gemcitabine and cisplatin for 4 cycles. So the study has been criticized because patients only received 4 cycles of gemcitabine and cisplatin and then received 6 cycles of dose-dense NVAC. And the question still remains, is it the number of cycles or is it the regimen? The other outcomes that have been reported also include pathologic response rate, which was again higher with the dose-dense NVAC, 42% versus 36% for patients receiving gemcitabine and cisplatin. And we did see some new outcomes reported at ASCO. The overall survival at 5 years was reported for all the patients. So this was a perioperative study. It also included adjuvant patients, but the biggest cohort was the neoadjuvant cohort, and that showed an improvement in overall survival for patients receiving dose-dense NVAC versus gemcitabine and cisplatin. Now, I think that this study is important in that we see that dose-dense NVAC is a good treatment option for patients with muscle-invasive disease. But again, it still remains, would gem-cis do as well if it was 6 cycles? So I think for now, both regimens are acceptable and not all patients can tolerate dose-dense NVAC. So we are limited by that. There has been also a lot of interest in looking at immune checkpoint inhibitors in the neoadjuvant setting, and several trials have asked this question with a monotherapy checkpoint inhibitor, or IO, with atezolizumab, pembrolizumab, nivolumab plus ipilimumab, durvalumab, and tremelimumab, and they have shown an overall response rate ranging, or a pathologic response rate ranging from about 31 to about 40%. So really promising overall response rates seen with either IO or IO. And also has been added to chemotherapy, gem-cis plus chemotherapy, again showing very nice pathologic complete response rates and downstaging of the tumors ranging in about 33% to as high as 50% with some combinations. And there's larger trials. These were smaller phase 1, phase 2 trials. There are larger trials that are ongoing right now, asking the question of neoadjuvant chemotherapy plus a checkpoint inhibitor in patients with muscle-invasive urothelial carcinoma, including durvalumab plus gemcis, nivolumab plus gemcis, and pembrolizumab plus gemcis. Well, what about an antibody-drug conjugate like enfortumab vedotin? Since it's so active in the metastatic setting, can we also give it in the neoadjuvant setting? And there are ongoing trials right now asking that question, including EV304 in patients that are cisplatin eligible, the Volga study, and EV303 in patients that are cisplatin ineligible. So I now want to move on to adjuvant therapy for muscle-invasive urothelial carcinoma. There have been 3 large trials that have been reported looking at improvement, looking at multiple endpoints, disease-free survival, overall survival, and looking at monotherapy checkpoint inhibitors in patients with muscle-invasive urothelial carcinoma. The first one, the IMvigor010, has been reported. There was no improvement in disease-free survival or overall survival. There was an exploratory analysis looking at ctDNA in the patients in this trial, and in the observation arm, ctDNA looked like it was prognostic, and in patients treated with atezolizumab versus observation, it looks like patients that were ctDNA positive had a greater benefit than patients in the observation arm if there was ctDNA positive. So this is exploratory, and there's an ongoing study right now, the IMvigor011, testing ctDNA, testing atezolizumab in patients that are ctDNA positive to see if there is a benefit in terms of disease-free survival and overall survival. The Checkmate 274 study is a study of adjuvant nivolumab in patients with muscle-invasive urothelial carcinoma. We've seen the results of that. The study showed an improvement in disease-free survival for adjuvant nivolumab versus placebo, and even a higher improvement in patients that were PD-L1 high. And this treatment is now FDA approved as of August 2021 for patients with muscle-invasive urothelial carcinoma. I had the benefit of presenting the outcomes of the Ambassador Alliance study. This is a phase 3 trial of adjuvant pembrolizumab for 1 year with the co-primary endpoint of disease-free survival and overall survival, and key secondary endpoints of disease-free survival and overall survival based on PD-L1 status. These are the patient characteristics from the study. I just presented this a week ago at ASCO, GU ASCO 2024. 702 patients were randomized. The arms were well balanced. About 2/3 of the patients received neoadjuvant chemotherapy. About 50% of the patients had lymph node positive disease. Over 50% of the patients were PD-L1 positive. About 20% of the patients had upper tract disease, and about 15% of the patients had variant histology. These are the results. The study met the primary disease-free survival endpoint with median disease-free survival of 29 months versus 14 months, benefiting adjuvant pembrolizumab versus observation, with a hazard ratio of 0.69 and a median follow-up of 22 months. We also looked at subgroups, and it showed a benefit throughout subgroups. The subgroup of upper tract was small, and the magnitude of benefit was unclear and should be further explored. Another outcome that we reported is disease-free survival based on PD-L1 status. We found that PD-L1 status was not predictive of benefit in terms of disease-free survival with adjuvant pembrolizumab, but it was prognostic. Patients that were PD-L1 high had a better disease-free survival and a better overall survival. This is the overall survival endpoint, the interim overall survival endpoint. It was not met with a hazard ratio of 0.98. The data is still maturing, and we await more events to assess the benefit in the final analysis. The median follow-up for this was 36.9 months. So now I want to talk about non-muscle invasive bladder cancer, and I'll focus on BCG unresponsive high-risk tumors. In the absence of intervention, BCG unresponsive carcinoma in situ will persist and progress. And currently, radical cystectomy is a standard option for patients that are BCG unresponsive and have non-muscle invasive bladder cancer. But there's a lot of morbidity, mortality, negative impact in life, and many patients refuse or are ineligible for cystectomy. So really, trial development has been focused on this space of BCG unresponsive, high-risk, non-muscle invasive bladder cancer. In January 2020, pembrolizumab received FDA approval for BCG unresponsive, high-risk, non-muscle invasive bladder cancer with carcinoma in situ with or without papillary tumors who were ineligible or refused cystectomy. This is based on the results of the KEYNOTE-057 study showing a complete response of 41% in 96 patients and a median response duration of 16.2 months. Another agent I wanted to talk about is intravesical nadofaragene firadenovec. This is a recombinant adenovirus that delivers human interferon alpha 2b cDNA into the bladder. This was tested in 151 patients in a phase 3 single-arm open-label study. It was given as a single intravesical dose of 75 mL and repeated at month 3, 6, and 9. The outcomes looked really fantastic in terms of a complete response at 3 months. 53% for patients with carcinoma in situ, 72.9% for patients with TA or T1 tumors, and for all patients, 59.6%, and it was very well tolerated. And based on this, in December 2022, the FDA approved nadofaragene firadenovec for adult patients with high-risk BCG unresponsive non-muscle invasive bladder cancer with carcinoma in situ with or without papillary tumors. So in summary, for the best of 2023 bladder cancer updates, there were 2 phase 3 trials in the first-line treatment of advanced metastatic urothelial carcinoma that have demonstrated an improvement in overall survival: nivolumab plus cisplatin and gemcitabine, and EV plus pembro. The combination of nivo plus cis-gem is the first chemo IO to show a survival benefit with a median overall survival of 22 months. However, the combination of EV plus pembro almost doubled the median overall survival compared to chemotherapy, with a median overall survival of 32 months, making it the new standard of care for patients in this setting. And now it's US FDA approved. So standard of care has changed for bladder cancer. EV plus pembro is now a first-line treatment for patients with metastatic urothelial carcinoma. Erdafitinib received full US FDA approval for metastatic urothelial carcinoma for patients susceptible that have FGFR3 alterations after progression of at least 1 line of systemic therapy. The label change is that erdafitinib is not recommended for the treatment of patients who are eligible for and have not received prior checkpoint inhibition. And adjuvant pembrolizumab demonstrated a statistically significant and clinically meaningful improvement in disease-free survival versus observation in the Ambassador study in patients with high-risk muscle-invasive urothelial carcinoma after radical surgery, regardless of PD-L1 status. These results support adjuvant pembrolizumab as a new therapeutic option for these patients. And finally, intravesical nadofaragene firadenovec was approved for patients with high-risk BCG unresponsive non-muscle invasive bladder cancer with carcinoma in situ with or without papillary tumors. So that wraps it up. That's the summary of the best of 2023 bladder cancer updates. And I want to thank you so much for your attention and for listening to all these updates. It's a lot of things are going on, and it's a very exciting time in bladder cancer right now. Thanks so much again for listening.
My name is Dr. Neeraj Agarwal. I'm a professor of medicine and director of genitourinary oncology program at the Huntsman Cancer Institute, University of Utah. Today, I'm going to be talking about therapeutic advances in metastatic or advanced prostate cancer in 2023. These are my conflict of interest. So we'll be discussing the three major advancements, or 3 or 4 major advances in 2023, starting from the EMBARK trial results in high-risk biochemically recurrent prostate cancer. Then we'll be talking about advancements in treatment of metastatic hormone-sensitive prostate cancer. And then we'll be talking about the advancements or results with PARP inhibitor combinations, and then, of course, with lutetium-177 treatment. So let's start with the EMBARK trial, which was presented by and published by Dr. Neil Shore and Dr. Friedland. Just to give you a background, we know that patients with localized prostate cancer who receive definitive radiation therapy, 20 to 25% patients experience disease recurrence characterized by rising PSA level. Patients who have high-risk BCR, as characterized by a PSA doubling time of less than 9 months, they are at a highest risk of prostate cancer-specific mortality. We also know from the large phase 3 trials in metastatic hormone-sensitive prostate cancer that treatment intensification with the ARSI or ARPI androgen receptor pathway inhibitors improve patients' outcomes. So objective of the EMBARK trial was to evaluate enzalutamide either alone or in combination with leuprolide compared to leuprolide monotherapy in patients with high-risk biochemical recurrence. This is the schema of the EMBARK trial, and we can see these patients had to have biochemical recurrence with a PSA doubling time of 9 months or less, and they were randomized to enzalutamide plus leuprolide, leuprolide alone, or enzalutamide alone. Primary endpoint was metastasis-free survival, and key secondary endpoints included overall survival. And these are the results. So the primary endpoint of metastasis-free survival was significantly improved when enzalutamide was combined with leuprolide compared to leuprolide alone, with about 60% reduction in risk of progression to metastasis. Now, let's look at the enzalutamide monotherapy, and this is the interesting part of the trial. Even enzalutamide monotherapy was superior to leuprolide monotherapy in patients with high-risk biochemical recurrence. Enzalutamide monotherapy improved progression-free survival with a hazard ratio of 0.63. Now, please note that these patients were allowed to stop the treatment or suspend the treatment if they were able to experience a PSA level of less than 0.2 at 36 weeks after starting treatment. And this is a part of the trial which has not been highly or widely discussed. So let's see how many patients underwent treatment suspension, or how many patients were able to experience a PSA of less than 0.2. So numbers seem to be highest in the combination arm, not surprising. If you look at enzalutamide monotherapy arm, that seems to be actually better than leuprolide arm as far as achievement of PSA of less than 0.2 is concerned. Accordingly, more patients on the enzalutamide monotherapy arm were able to discontinue or suspend the treatment than the leuprolide arm, which is also a novelty from this trial. Now, if you look at the median duration of treatment suspension, so once they suspended treatment, how long they were able to be off treatment. And again, enza with leuprolide did best. These patients were able to suspend treatment for 20 months. However, even enzalutamide monotherapy patients were able to suspend treatment for 11 months, median duration. We are not surprised by the treatment suspension duration of 16 months in the leuprolide arm, because many of these patients probably did not recover their testosterone, having received leuprolide for 36 weeks, which is almost 9 months. So many of these patients as we can see here, who are very reluctant to start castration therapy, based on these results, may be treated with enzalutamide monotherapy for their high-risk biochemical recurrence, and many of them will be able to suspend treatment to recover from their side effects. So if you look at the safety profile, obviously we didn't see any new safety signals. The gynecomastia was quite common in the enzalutamide arm in up to 45% patients. However, sexual function were improved with the enzalutamide monotherapy arm. And my take on the EMBARK trial results, that enza combined with ADT was superior to single agent ADT, but enzalutamide monotherapy also seemed to be superior to ADT alone. And side effects were similar except gynecomastia, nipple pain, which were more frequent with enzalutamide monotherapy, and sexual function were improved in the monotherapy arm. Many of these patients will have metastasis on the PSMA PET scan now. And my take is now they have the opportunity to receive enzalutamide without having to wait for metastasis on the conventional scans. And if they want enzalutamide monotherapy, these results provide them the opportunity to receive enzalutamide monotherapy. So with that, I will move to metastatic hormone-sensitive prostate cancer. And also bring up the debate on doublets plus triplets. We'll talk about some biomarkers, and then my take on these advancements. So we can see here, over last decade, we have seen multiple agents, intense agents when combined with standard ADT, improving survival. So these are the doublet therapy trials. And I want you to focus on the doublet therapy with ADT plus an ARPI, or androgen receptor pathway inhibitor. And we can see that consistently, there was a 35% reduction in risk of progression or death, or this is overall survival. So risk of 35% reduction in risk of death by adding ARPI to ADT across the board. Abiraterone, enzalutamide, or apalutamide. Very consistent results. And please note that overall survival is improved across the subgroups, except maybe in those patients who have visceral metastasis. And we know these patients mostly have liver metastasis, which predict poor survival, which is associated with poor survival. So in those patients, 7 to 10% patients who have liver metastasis at the time of initial presentation, they may not be the best candidate for ADT plus ARPI doublets, but or they may not be responding as well to ARPI doublets, but every other group seem to be benefiting. Now let's look at the triplet therapy trials. And these were ADT plus docetaxel plus ARPI versus ADT plus docetaxel. So we do not have the answer regarding comparing a triplet with ADT plus ARPI. So we have the answer regarding ADT triplet, ADT plus ARPI plus docetaxel versus ADT plus docetaxel. And we can see here that the outcomes are better when we add ARPI to ADT plus docetaxel. Again, I'm not surprised by this. We probably expected this. ARPI is another potent therapy. And if you add that to the backbone of ADT plus docetaxel, survival improves. So what we have seen just now, that triplet improves outcomes compared to ADT plus docetaxel. However, we don't have the information on whether triplet improve outcome versus ADT plus ARPI. So what can we do? How can we personalize medicine? If I have to choose a ADT triplet, ADT plus ARPI plus docetaxel, or ADT plus docetaxel, or a ADT plus ARPI, obviously ADT plus docetaxel is clearly inferior to triplet. So the choice is between ADT plus ARPI doublet versus ADT plus docetaxel plus ARPI triplet. So we know that patients who do not experience a PSA of 0.2 or less in first 6 months, they have the worst prognosis. So these are the data from 3 large trials, and we have reported these data in various meetings and publications. So these are the patients who do not experience a PSF 0.2 or less. They are the higher risk of death and time to CRPC and so on. So this is the data we have. So can we design trials where we will only use triplet for those patients who do not experience or who are not able to achieve a PSA of 0.2 in the first 6 months? Thus, we can save docetaxel chemotherapy for those patients who are at the highest risk of death when they are starting ADT plus ARPI. Or patients with liver metastasis, for example, we saw they do not seem to be benefiting with ADT plus ARPI. So can we reserve the triplets for those patients? However, or on the other side, patients who are able to experience a PSA of 0.2, can we de-escalate? Can we de-intensify the treatment for them? Because we know these patients are going to be living for a long time, and they will be dealing with a lot of long-term side effects, which may not have been captured by these clinical trials. And hence, we need to be thinking about de-escalation or de-intensification of treatment in these patients. So fortunately, multiple trials have started in this direction. So this is what we saw in last year. Multiple de-escalation trials started. This is de-escalate trial from EORTC, but patients experiencing a PSA of 0.2 or less will be randomized to continuation of the ADT plus ARPI doublet or whatever systemic therapy they are getting versus intermittent treatment with those doublets or triplets. There's another trial, a DREAM trial. Again, very similar strategy for patient selection. So patients who achieve or experience a PSA of 0.2 or less, they will be able to interrupt or de-intensify the treatment. We started this trial of Libertas, which called as Libertas phase 3 trial, where patients with newly diagnosed metastatic prostate cancer who are starting treatment with ADT plus apalutamide, and when they experience a PSA of 0.2 or less, they will be randomized to continuation of ADT plus apalutamide versus ADT apalutamide plus intermittent ADT. And hopefully many of these trials will show acceptable outcomes with intermittent or de-intensification agents or regimens. And hopefully we'll be able to give some break to our patients with newly diagnosed metastatic hormone-sensitive prostate cancer who are experiencing a PSA of 0.2 or less within 6 months of starting the ADT plus triplet or doublet therapies. Can biomarkers help? So we have reported in the past this project led by my colleague, Dr. Swami in the Huntsman Cancer Institute, that patients who have SPOP mutation, they have much improved survival with ADT doublets versus who did not have SPOP mutations. But when you look at the influence or effect of SPOP mutations in the context of chemotherapy, we didn't see any differential benefit. Dr. Ellen Bryce and team from Mayo Clinic have reported the effect of P10, RB1 loss, and T53 loss. So these are the tumor suppressor genes. And if we see the loss of these genes, that may be associated with inferior outcomes on intensification agents or ADT intensification. So can we preferentially enroll these patients on the trial who have lost tumor suppressor genes in their tumors? And can maybe patients who have SPOP mutation should only consider ADT plus doublets or ARPI doublets because they seem to derive unusually higher magnitude of benefit with ADT plus ARPI doublets. And fortunately, many biomarker-based trials are ongoing right now. We are conducting the TALAPRO-3 study and amplitude trial, where patients with homologous recombination repair mutations are being randomized to standard of care therapy plus minus PARP inhibitor, which is talazoparib for TALAPRO-3 trial, niraparib for amplitude trial. There's a trial known as CAPITULA trial, which is enrolling patients with PTEN deficiency, and these patients are being randomized to ADT plus abiraterone plus minus capivasertib, which is a AKT inhibitor. PSMA addition trial is recruiting patients based on PSMA expression. So ultimately, I think we will be looking at a very personalized approach as far as treatment of MHSPC is concerned, where patients will be offered a treatment strategy based on underlying genomic or functional abnormalities as far as mutations are concerned, or as far as PSM expression is concerned, or as far as presence or absence of SPOP mutation is concerned. So overall, my take on treatment of MHSPC is that there is no role of ADT alone, except in small number of patients where life expectancy is less than 2 years. Doublets of ADT plus ARPI are applicable to most, except those with visceral metastasis or some other high-risk features. We can comfortably say that current triplets replace only ADT plus docetaxel. And I think biomarker-based ongoing trials will lead to increasing personalization of treatment of MHSPC. And given increasing overall survival, we need response biomarker-based escalation and de-escalation treatment strategies, which are being tested in the clinical trials. So now let's move on to metastatic castrate-resistant prostate cancer. Before I delve into mCRPC, I would like to bring your attention to the fact that metastatic CRPC is a much larger disease setting than metastatic hormone-sensitive prostate cancer. In fact, in the United States, only 20% patients are diagnosed to have prostate cancer as metastatic castration or metastatic hormone-sensitive prostate cancer. Most patients actually ultimately progress to mCRPC through localized prostate cancer or locally advanced prostate cancer. So we expect most of these patients to not have been exposed to novel hormonal therapy or ARPI when they develop metastatic castrate-resistant prostate cancer in the US and also in many other parts of the world. So with that in mind, I'll move to the combination PARP inhibitor plus NHT treatment in our patients. So we know from the preclinical data that patients who are treated with novel hormonal therapy or NHT, their phenotype may resemble homologous recombination repair deficiency because suppression of AR function can cause upregulation of poly-ADP ribose polymerase. Similarly, we know that poly-ADP ribose polymerase support AR function, and AR or PARP inhibition may actually attenuate resistance to NHT. So we give PARP inhibitors that may make NHTs more effective. So I will show you the results of these three trials, PROPEL, MAGNITUDE, and TALAPRO-2 study, which randomized patients with newly diagnosed mCRPC to a PARP inhibitor plus novel hormonal therapy or ARPI versus novel hormonal therapy. So for the PROPEL trial, it was abiraterone plus olaparib versus abiraterone. In the MAGNITUDE trial, it was abiraterone plus niraparib versus abiraterone. And for TALAPRO-2 trial, it was enzalutamide plus talazoparib versus enzalutamide. The last trial, the CASPAR trial, which was testing rucaparib as one of the PARP inhibitors, the accrual has been halted prematurely. So we do not know whether this trial will be completed down the line. So this is the schema of all these three trials. Overall, they are more similar than different. But the bottom line is these patients had newly diagnosed mCRPC, and they were randomized to a PARP inhibitor plus ARPI versus a ARPI. Now, in the MAGNITUDE trial, that was tested separately in the HRR positive and negative patients. In the PROPEL trial, all patients were tested together. They did not have any pre-specified, they did not have the knowledge like who had HRR positivity or negativity before enrollment, but all patients had their HRR status determined after enrollment. And in the TALAPRO-2 trial, there was a prospective comprehensive genomic profiling of the tissue or the ctDNA to determine who had HRR positivity or negativity or unknown status before they were randomized to the two arms of enzalutamide plus talazoparib versus enzalutamide plus placebo. So these are the schema of these three trials. And let's look at the results. Again, we saw, as we discussed in the past, we have presented in the past, these are striking results in patients with BRCA1 and BRCA2. The hazard ratio was 0.23, 75% reduction in risk of progression of death by adding either olaparib to abiraterone or talazoparib to enzalutamide. These are striking benefit in progression-free survival. If you look at the homologous recombination repair mutations, all of them, excluding patients who did not have homologous recombination repair mutations. So if you look at all homologous recombination repair mutations, including BRCA1 and BRCA2, there was a 50% reduction in risk of progression on death by adding olaparib, or a 55% reduction in risk of progression or death by adding talazoparib to enzalutamide. The data with niraparib, of course, this is across the trial comparison. So these are different patient population, different drugs. They have different demographics, different disease characteristics. But as I said, despite all those caveats, the ADT plus niraparib, or adding niraparib to ADT to abiraterone, does seem to have a bit higher hazard ratio in patients with HRR positivity or patients with BRCA mutations compared to olaparib or talazoparib data. And please note that in patients who did not have HRR mutations, in the magnitude trial, the addition of niraparib did not show any benefit. So to look at the regulatory approval in the United States, abiraterone plus olaparib is approved for patients with mCRPC with BRCA1 and BRCA2 mutations only. And similar is the case for abiraterone plus niraparib. However, for the combination of enzalutamide plus talazoparib, patients with mCRPC with any HRR mutations are eligible for treatment with enzalutamide plus talazoparib. And that's the FDA approval. If you look at the EMA approval, in the EU, the approval label is more broad. So they include patients with mCRPC when chemotherapy is not indicated, for the olaparib abiraterone combination, and for enzalutamide talazoparib combination. With that, I think I'd like to also highlight the other data, which are based on, like, if you look at the objective responses in the TALAPRO-2 trial. By the way, in the all-comer cohort, there were only 7% patients with BRCA1 and BRCA2 mutations. And if you look at patients who had complete responses, there were 18% higher responses by adding talazoparib to enzalutamide. So it does seem like more patients beyond BRCA1 and BRCA2 mutations are benefiting by adding talazoparib. And I know this has been a debate whether any other patients benefit. I think this is a clear signal that more patients beyond BRCA1 and BRCA2 mutations are benefiting by adding talazoparib. If you look at the second cohort of the TALAPRO-2 trial, which only included patients with HRR mutations, we clearly see benefit beyond BRCA1 and BRCA2 mutations. And we can see patients with CDK12 mutation, for example, there was a 50% reduction in risk of progression of death. There was also an indication in patients with PALB2 mutations. And of course, these are very small subsets. And trial was not powered to assess for primary endpoint, these small subsets. But there is clear indication that patients beyond BRCA1 and BRCA2 seem to be benefiting by adding PARP inhibitors to the androgen receptor pathway inhibitors. And this is just the beginning of the story. I know PARP inhibitors will have increasingly bigger role to play in the coming years. These are multiple trials which are going on with PARP inhibitors in combination with radioligand therapy, with other immune therapies, chemotherapies. And hopefully we'll see some of these trials to be panning out into phase 3 trials, and hopefully we'll see some of those trials to be positive. I'd like to bring your attention to this abstract BRCA-WAIT trial, which was presented by Dr. Maha Hussain in GU ASCO 2024. Although I'm focusing on the data from 2023, I thought it would be important to discuss these results because we are talking about combination therapies. This is a small trial. This is a limitation of patients with mCRPC with BRCA1, BRCA2, and ATM mutations. And I want you to focus on the left side of this picture. There were 3 arms: abiraterone only, olaparib only, and abiraterone plus olaparib. So this trial asked a question which none of the phase 3 trial asked, which is, what happens if you compare the doublet with olaparib monotherapy? Interestingly, the monotherapy patients were allowed to cross over to olaparib for abiraterone arm and to abiraterone in the olaparib arm. So let's look at the primary endpoints. It was radiographic progression-free survival. And if you look at baseline characteristics, the BRCA, if you look at the BRCA2 mutation, that seemed to be more common in the olaparib arm, but they were not more common in the combination of abiraterone plus olaparib. Now let's look at the results. Not surprisingly, we see that patients on arm 1 had a median PFS of 8.4 months. Patients on arm 2 had a median PFS of 14 months. And patients on arm 3, abiraterone plus olaparib, had a median PFS of 39 months. Quite striking difference. Very striking in my view. Now, interestingly, if you look at the patients who were able to cross over from abiraterone to olaparib, if you look at the combined PFS of abiraterone plus abiraterone followed by olaparib, it was 16 months. If you look at patients who got olaparib first and then move on to abiraterone, the combined PFS from the randomization to end of crossover treatment was 16 months. And then if you look at the abiraterone plus olaparib arm, the median PFS is 39 months. So these data suggest that upfront combination is better than monotherapy. And for the first time, I'm convinced that there is a synergy between abiraterone plus olaparib when you combine them upfront, because it doesn't seem like addition of the efficacy of abiraterone plus olaparib when you combine them. So based on these data, I'm increasingly enthusiastic to offer upfront doublet therapy with ADT plus with abiraterone plus olaparib or enzalutamide plus talazoparib in patients with newly diagnosed metastatic castrate-resistant prostate cancer. And in the US, they have to have HRR mutation for talazoparib and BRCA1, BRCA2 mutation for using olaparib or niraparib. Now, next steps will be to figure out what is driving the benefit in HRR negative patients and what happens when these patients start progressing on a PARP inhibitor. With that, I will come to the last portion of this talk, which is role of lutetium 177. We saw the data from Vision trial being presented in 2022. We saw the PSMA4 data being presented by Dr. Sauter in ESMO 2023 meeting. And this is the comparison of Vision trial and PSMA4 trial here in front of you. Both trials met the radiographic progression-free survival endpoint. Vision trial also showed an overall survival benefit of about 25% reduction in risk of progression or death, and a 60% reduction in risk of progression or death by adding lutetium to standard of care therapy in the Vision trial in the post-chemotherapy setting. In the PSMA4 trial, where lutetium 177 was tested in a pre-chemotherapy setting. So in this trial, in the PSMA4 trial, as presented by Dr. Sauter, patients who were progressing on a novel hormonal therapy, they were randomized to lutetium, PSMA versus ARPI change. And we saw a radiographic progression-free survival benefit of about 6 months with a hazard ratio of 0.43, 60% reduction in risk of progression or death. And there were patients, like 84% patients crossover. So I think that is one reason why we don't see a survival benefit here. But regardless, there is a clear signal of benefit by using lutetium-177, PSMA-617 before chemotherapy. And we saw the press release on the SPLASH trial, very similarly designed trial to PSMA-4 trial. And here's the comparison of SPLASH trial data, which are publicly available, versus PSMA-4 trial. And we can see here that SPLASH trial, which used a different carrier molecule. So the radioactive particle is same, lutetium-177, but the carrier is PSMA-INT. And in this trial, the doses were different, 6.8 GBq every 8 weeks of 4 cycles. In SPLASH trial, in the PSMA-4 trial, we can see the doses are higher, 7.4 GBq every 6 weeks for 6 cycles. So there's clearly a different dose being given to the patients. And probably we see that being reflected in the radiographic PFS benefit, with a 30% reduction in risk of progression or death with the lutetium-177 PSA-INT versus a 60% reduction in risk of progression or death in PSMA-4 trial with lutetium-177 PSA-617. And anytime we discuss lutetium-177 treatment, I like to discuss the therapy trial, which was a small trial, 200-patient trial, where patients who had high expression of PSMA, so SUV max had to be more than 20 on any site, and any measurable disease had to have a SUV max of more than 10. So this is a high PSMA expressing patients who are randomized to lutetium PSMA versus cabazitaxel. So progression-free survival, PSA responses seem to be favoring the lutetium-177, but the overall survival seemed to be similar. Of course, with the caveat, the trial was not powered for this endpoint. Trial is not large enough, but we really don't see any overall survival signal, at least in this trial. So based on this, my take on the lutetium PSMA data is that, first of all, the access still remain challenging for many parts of the world. In the US, it has become much easier now. It is easily available, widely available. So it is a valid therapy backed by category 1 evidence for our patients who have progressed on a chemotherapy. We don't have lutetium-177 approved yet in patients who have not received chemotherapy in castrate-resistant setting. And based on the therapy trial data, cabazitaxel is an acceptable option in patients with mCRPC with high PSMA expression and should be offered in mCRPC with low PSMA expression in those who have already progressed on docetaxel chemotherapy and have limited treatment options. So cabazitaxel remains a valid therapy for those patients. And in pre-docetaxel setting, we see lutetium PSMA-617 showing benefit in the PSMA-4 trial and hopefully will be approved in the near future. So to conclude my talk, we have seen a fantastic pace in the drug development in prostate cancer in the last decade. Recent additions are PARP inhibitors and lutetium-177 therapy. In the absence of head-to-head comparison and biomarkers for most agents and access issues, the art of medicine will continue to play a big role in patient selection and sequencing of these agents. My take, anytime we can intensify, we should try to do that. Intensification seems to work in hormone-sensitive metastatic prostate cancer and also in metastatic castrate-resistant prostate cancer. Our eventual goal is to maximize receipt of life-prolonging agents while maintaining quality of life. And also, I think it's time for response biomarker-based de-escalation and escalation trials. So thank you very much for your kind attention. And I'd like to acknowledge my team at the Huntsman Cancer Institute and my colleagues. Thank you very much.
Dear colleagues, friends and guests, it's my pleasure to present on Urology Update 2023, what is new in 2023, and I'm happy to welcome you online here in this format, and thank you for organizing this excellent multidisciplinary symposium from OncoAlert. My name is Axel Merseburger. I'm a professor of urology here at Lübeck University, in Lübeck, Schleswig-Holstein, northern Germany. This is my agenda, and I thought to go with you through 5 points. Very briefly, very quick: prostate cancer screening, then biochemical recurrence, then PSMA PET imaging, then the OPERA trial run by my friend Mark-Oliver Grimm, and latest developments of adjuvant therapy in bladder cancer and renal cancer, with some news coming up at ASTRO GU now next week. So what about prostate cancer screening, and why forget about the finger and digital rectal examination like DRE, and why should we forget about it? And let's have a look. Smart screening nowadays really is different. We have age, we have family history, we have a prostate-specific antigen and new biomarkers in use, and especially what is very new is the MRI and then MRI-guided biopsy, and that is the reason why we probably should forget about DRE, or at least question ourselves if we do something good for our patients. Because in Germany, Professor Peter Albers has run with a lot of colleagues the PRO-based trial. This is a risk-adapted prostate cancer early detection study based on baseline PSA value in young men, prospective randomized multicenter trial with almost 50,000 participants now. Some of the data is published, and here have a look at the design. Depending on the baseline PSA, imaging and diagnostics, further diagnostics and biopsy have been performed. And the results of PSA screening at the age of 45, where it's recommended, you could see detection rate was 48 prostate cancers. And especially here in the gray zone of 3, we can detect some prostate cancer with MRI, and MRI really helped to avoid unnecessary biopsies. So looking at this, the annual digital rectal exam starting at the age of 45 just caused a lot of false positive findings without prostate cancer, and a lot of avoidable biopsies. And the digital rectal exam in man with histological confirmed tumors, is shown in this publication of last year, shows that the investigation is not as sensitive as we thought. So in summary, and let me just remove this picture to read, population-based screening with PSA alone is not sufficient and can result in harm. Personalized screening based on age is simple and efficient, and the baseline PSA of 45 to 50, and 90% of those men are at low risk, and you can confirm 5 years later. High quality MRI really has changed a lot how we detect prostate cancer nowadays. So implementation on those results on a community level is urgently needed, and I urge you also to read those publications of Peter Albers and the team on the very important PRO-based trial. What about biochemical recurrence? There's an EMBARK trial came out last year, a topic we are focusing a lot, face a lot with our patients. PSA rise after radical prostatectomy, for example, or after radiation therapy. And here, last year, the New England Journal publication, the EMBARK trial, I would like to summarize. Looking at Xtandi here, using Xtandi, what you know in mCRPC and hormone-sensitive prostate cancer, now being explored in a more earlier phase in patients with high risk of biochemical recurrence, a PSA doubling time of less than 9 months, a PSA more than 2 nanograms, normal testosterone, and a good fit ECOG performance status. This is a trial design, a Lupron versus Lupron plus placebo versus enzalutamide monotherapy, and the first arm Lupron plus enzalutamide, and a primary endpoint was metastasis-free survival for those men with biochemical recurrence. And you can see that the MFS for enzalutamide combination versus Lupron alone has a high hazard ratio in favor of enzalutamide combination compared to Lupron alone, hazard ratio 0.4. So EMBARK is on the one hand intensification and also de-intensification. So if after 36 weeks the PSA dropped to 0.2, it was stopped, the whole therapy, and then restarted at 5 nanograms after after radiation therapy and 2 nanograms per ml after radical prostatectomy. So very smart design, trial design shown here in the EMBARK trial. Again, the curves enzalutamide plus ADT versus ADT alone, MFS benefit for the combination, and here enza alone versus ADT alone, also a benefit of enzalutamide compared to ADT alone in those men. The overall survival, the trend towards better overall survival in the combination arm, not statistically significant at this point. So how to treat biochemical recurrence remains a very heterogeneous clinical scenario. Some patients will progress, some will die. Most also will die of other causes. Early salvage radiotherapy is very effective. And now we have in some countries enzalutamide approved in this situation or investigated in high-risk biochemical recurrence patients. Enzalutamide plus ADT improves MFS over ADT alone. And definitely better treatment selection will help in the future. And there are also some ideas how to solve this. And here, just an idea, I'm not going into detail, work by Dan Spratt here, excellent AI for prostate cancer, artificial intelligence, predictive model for hormone therapy use in prostate cancer. I think something like this can be the future, and AI use like the Altera test is already available in some countries like the US. Showing like the test report here, an example from their webpage, prognostic risk, additional prognostic endpoints, and in order to decide whether or not ADT should be combined with radiation therapy. I think those smart tests can help in the future on how we treat our men with biochemical recurrence or in case of salvage radiation or radiation therapy. Modern imaging, just to repeat, we are still using PSMA PET, and the data from Australia here showing that PSMA PET shows a greater accuracy than conventional imaging. Kudos to the colleagues showing that PSMA out of the PSMA study has superior accuracy, greater treatment impact, and fewer uncertain results, and has become one of the standards in high-risk localized prostate cancer or for detecting recurrent prostate cancer after, for example, radical prostatectomy. So pro-PSMA PET study really has established this PSMA PET in primary staging, has changed the guidelines, less radiation, it's cost effective. However, the overall survival impact will need to be investigated in the future. Moving to renal surgery, we have laparoscopic and we have robotic surgery competing against each other. And here the OPERA trial led by Mark Oliver Grimm has nicely looked at quality of life and complications in robotic versus laparoscopic, a partial nephrectomy in intermediate and high complexity renal tumors. This is the OPERA study design, and the screened patient consented, and 240 were randomized. 117 underwent robotic partial nephrectomy and 90 the OPN. And looking at robotic versus robotic versus the open. Here, the open arm was less than the robotic trial. This is due to patient withdrawal consent when they find out they were in the open arm. They wanted laparoscopic, or in this case, robotic surgery. Now, this trial has shown in the previously reported endpoints with regards to postoperative fewer complication in robotic compared to open partial nephrectomy. The conclusion it is less pain associated with robotic partial nephrectomy, less use of opioids, and so quality of life-wise, as pointed out by the group at the EAU meeting in 2023, is in favor of robotic partial nephrectomy compared to open partial nephrectomy. Concluding this short session, what about adjuvant therapy? What about when we've done everything correct, did surgery for bladder cancer or for renal cancer, but know that we have an advanced stage of the disease, know that we have advanced TNM stadium, and now we have treatment for those men and women and patients with high-risk disease. And I would like to start with the pembrolizumab trial, the keynote trial, looking at pembrolizumab post renal surgery for clear cell renal cell carcinoma. A nice work by Toni Choueiri on pembrolizumab versus placebo, and you can see in the curves disease-free survival is in favor of pembrolizumab. This led to approval of pembro in this indication, and now we recently saw at the ASTRO GU meeting the data of overall survival benefit of this combination, pembrolizumab. And the conclusion is the results support the use of pembrolizumab as adjuvant therapy in patients who have had surgery in renal cell carcinoma with renal cell carcinoma and have a high risk of recurrence. So we have options to prevent recurrence and prolong overall survival in patients with renal cancer. The same accounts for bladder cancer. Here, FDA and other regulators have approved nivolumab as an adjuvant treatment for patients with urothelial carcinoma who are at high risk of recurrence undergoing radical resection. This is the approval is irrespective of the prior neoadjuvant chemotherapy, nodal involvement, or PD-L1 status, really showing an adjuvant IO treatment for bladder cancer. So taken together, I really have to say we are living and should continue to work in a very multidisciplinary fashion. That's why I thank OncoAlert to connect the dots here to spread the news in GU cancer and all other cancers. Thank you for watching. Hope you enjoyed my short summary on urology, oncology. Thanks a lot.
Hello, everyone. My name is Sophia Kamran. I am a GU radiation oncologist in the Department of Radiation Oncology at the Mass General Cancer Center, as well as an assistant professor of radiation oncology at Harvard Medical School. I'm delighted to be here to present the best of GU radiation oncology as per what was presented at ASTRO this past year in 2023. So I'd like to just talk about a certain number of trials that were presented, just highlighting these. I'm going to start with NRG RTOG 0415, NRG RTOG 0126, PACE-B, Formula 509, and the Fast Track 2 trial. Broadly, this can be divided up into intact prostate trials regarding the first three, followed by post-op prostate, Formula 509, and then non-prostate GU, specifically RCC, renal cell carcinoma. So let's get started. So we'll first start with the intact prostate trials. So the first that I'm going to discuss is the long-term follow-up analysis of NRG Oncology RTOG 0415, a randomized phase 3 non-inferiority study comparing two fractionation schedules in patients with favorable risk prostate cancer. This was presented by Dr. Robert Lee at Duke University. So broadly, looking at the schema, so eligibility criteria included men with low risk prostate cancer, generally greater than 18 years old, Gleason scored between 2 and 6, and PSA less than 10. Again, the design was a phase 3 non-inferiority randomized trial. They had over 1,100 patients enrolled. In terms of the treatment, there are two fractionation schemes, 73.8 gray and 41 fractions, and 70 gray and 28 fractions. The CTV to PTV expansion was 4 to 10 millimeters, and there was no androgen suppression allowed in this trial. There are some stratification factors, as you can see listed below. In terms of endpoints, the primary endpoint was disease-free survival between the two arms, and additional endpoints included overall survival, prostate cancer-specific survival, time to local progression, and time to biochemical recurrence. As I mentioned before, this is long-term follow-up to the original publication, which was published in 2016 in JCO. And this is what they were just trying to find. So again, just reminding everyone that many contemporary randomized trials have not demonstrated increased efficacy with hypofractionation, but that's what the goal of this study was. So looking at patient tumor characteristics between the two arms, you can see that the majority of patients had a PSA between 4 and 10. And then you can see the Gleason score was between 5 and 6, as well as the T stage was mostly clinical stage T1. Now, looking at the primary endpoint between 2016 and 2023, so the primary endpoint was disease-free survival. On the left-hand side, you can see with a median follow-up of 5.8 years, there was no significant difference between the two arms. And that's actually remained the same in terms of the median, with longer median follow-up of 11.9 years, there's no difference between the two. And then in terms of biochemical failure, there was no significant difference on the left-hand side in the original publication between the two arms. However, there does appear to be a difference between the two arms with a longer follow-up favoring the hypofractionation schedule. So you can see its biochemical failure rate. The hypofractionation is in red, whereas the conventional fractionation is in blue. And you can see that there is an improvement in biochemical failure. And then in terms of late adverse events, that's something that is always a concern when looking or thinking about moderate hypofractionation or any type of hypofractionation trial, specifically genitourinary toxicities or gastrointestinal toxicities. And as you can see from these data here, that there is no significant difference in terms of grade 3 or higher GI or GU toxicity, which is reassuring. So, to put this into perspective, this trial is similar to other trials showing non-inferiority of moderate hypofractionation to standard fractionation. And, some takeaways from this study is that, for men with low risk prostate cancer, moderate hypofractionation is non-inferior to standard or conventional fractionation with respect to disease-free survival. With longer follow-up, there's now a significant reduction in biochemical failure with moderate hypofractionation, but there's no significant difference in late grade 3 or higher toxicities. So, what this begs the question of, if the biochemical failure is reduced with hypofractionation, is that an early precursor for distant metastases or overall survival, which are endpoints of, that are critically important for patients with prostate cancer. So, we don't know that for sure yet. So my take is, in this unique population of low risk prostate cancer patients, my take is that, there are many, many options for patients with low risk prostate cancer, including active surveillance, from the data from the PROTECT trial that was also recently updated in 2023. Of course, for patients that are eligible, surgery is always an option, brachytherapy or external beam radiation. So, but, for those that are interested in external beam radiation approach or an external beam radiation approach, moderate hypofractionation is effective and safe. So next, I'll pivot to the RTOG-0126 trial. So this is long-term outcomes of NRG RTOG-0126, a randomized trial of dose escalation. So high dose, 79.2 versus standard dose, 70.2 radiation therapy for men with localized prostate cancer. And this was presented by Dr. Mikulski at WashU. Briefly, this is the schema and eligibility criteria for this study. So as you can see, eligibility included patients with clinical T1B to T2B, Gleason score 2 to 6, and PSA between 10 and 20, or patients had Gleason score 7 and PSA less than 15. The design was a phase 3 randomized trial, and there were over 1,500 patients enrolled. In terms of treatment arms, so one arm had minimum PTV prescription of 70.2 gray, and then the other arm had a minimum PTV prescription to 79.2 gray. The CTV to PTV expansion was 5 to 10 millimeters. And again, no androgen suppression was allowed. And you can see there were certain stratification factors below, and the primary endpoint was overall survival, and additional endpoints included biochemical failure, both the ASTRO and Phoenix, by both the ASTRO and Phoenix definition, distant METs, local progression, prostate cancer mortality, and time to late grade 2 or grade 3 or higher GU and GI toxicity. Again, so this is an update, a long-term update from the original publication, which was published in 2018 in JAMA Oncology. So looking at that primary endpoint of overall survival, as a reminder, the primary endpoint was overall survival. So on the left-hand side is the data from the original publication 2018. Right-hand side was what was presented at ASTRO 2023. So as you can see, no significant difference between the two arms in terms of overall survival. And you can see with longer follow-up, there's still no significant difference between the two arms. You can see by this hazard ratio, and you can see by the p-value here. And 79.2 is in red and 70.2 is in blue. Then some other interesting endpoints. So time to prostate cancer death. So we do see with the original publication, again, no significant difference between the two arms for this particular endpoint. However, we do see that there is a favoring of the dose escalated treatment arm for time to prostate cancer death. And so that was something that was new with the longer follow-up that was not in the original publication. And then similarly, time to distant METs. So on left-hand side, this was what was presented in the original publication. Right-hand side was what was presented in 2023. So as you can see, with shorter follow-up, there was no significant difference between the dose escalated arm and the standard arm. However, with longer follow-up, there was a favoring, and it was actually statistically significant for the dose escalated arm. We can see that there's a trend toward favoring towards an improvement in decrease in distant METs in the dose escalated arm in the original publication, but this did not meet statistical significance. However, with that longer follow-up, we are seeing that improvement, and we can see that it is now statistically significant. And then, finally, time to first salvage therapy, and we can see that there is a benefit to the dose escalated arm in terms of this endpoint, and that was statistically significant. And this is in line with the initial publication showing a decreased use of salvage therapies in the dose escalated arm. Time to late adverse events, we can see in terms of grade 2 or GI or GU toxicity, there is an increase of these in the dose escalated arm. However, for grade 3 toxicities, there is no significant difference between the two. So again, these are just some randomized dose escalation trials that are known in the field, and this is just adding additional data, an additional data point to this table. In the history of dose escalation trials, there has not been a trial that has shown an improvement in overall survival with dose escalation. However, there have been significant improvements in other endpoints of interest, of importance, such as distant metastasis-free survival, freedom from biochemical failure, et cetera. But there just has not been a dose escalated trial demonstrating overall survival benefit. I am currently at ASCO GU 2024, and earlier today there was data presented by the data from JATUG 18 was just presented. It's a different patient population, but again, similarly, it was a dose escalation trial. It was 70 gray versus 80 gray. It was in a high risk population, and all patients received long-term ADT. And this is the first trial that was just presented, demonstrating an overall survival benefit to the dose escalated arm. So it's very exciting. We obviously need a bit more information. We want to see the publication, but it's a very similar trial to the Mikulski trial that I'm presenting here, except the patient population was drastically different. But in terms of the dose escalation arms, they were similar. So as you can see in the publication, in the presentation that I'm giving right now, in the Mikulski's presentation, No improvement in overall survival, no difference at 10 years. However, there was an improvement in overall survival with the JTUG 18 trial. So we'll need to do a little bit more parsing out. One thing that was mentioned is that in the arm that received the dose escalation, the 80 gray, majority of patients received IMRT. And so that may have played a difference, or may play a role, or there might just be something different with the patient population, or the fact that all patients received long-term ADT in that particular population. So we need to parse out a little bit more about what's going on, but it is exciting. So in conclusions from this trial, the RTOG 0126, for men with intermediate risk prostate cancer, dose escalation with conventional fractionation did not improve overall survival. However, it did improve other endpoints, including time to distant mets and time to prostate cancer death. That was new with a longer follow-up as compared to the original publication, as well as local control and biochemical disease-free survival. That was similar to the original publication. So that's why I didn't highlight that here. Also, the dose escalated arm was associated with significantly less salvage therapies, which is important for patients, when you're thinking about additional toxicity and also impact on quality of life. And dose escalation was associated with increased grade 2 or higher GI/GU toxicities, but not grade 3 or higher toxicities. So, my take is these observations are in line with dose escalation trials, as I mentioned before, including for brachy boosts such as AscendRT and intraprostatic focal boosts such as FLAME. Again, not seeing an overall survival improvement, but improvement of other endpoints. And of course, we're going to have to think about this trial in the context of the recently presented JTUG 18 trial that I just mentioned. Fewer salvage therapies may mean improved quality of life, as I mentioned as well. And, is it, the reduced prostate cancer specific mortality, the distant mets, and, the salvage therapies, is that enough to warrant treatment with dose escalation despite no overall survival difference? So these are things we have to think about, especially in the context of our patients. And then finally, the field has moved more towards hyperfractionation and ultra hyperfractionation and dose escalation via focal boosts and incorporation of genomic classifiers to personalized treatment. So thinking about dose escalation in the context of these particular points will also be important moving forward. So next, in the last trial I want to highlight in the intact prostate group is the PACE-B. So 5-year outcomes from PACE-B was presented by Dr. Van Ass, and this was very exciting because this was actually showing the primary outcome data. So PACE-B has been presented before in terms of looking at toxicity, both acute, that was actually published, and also 2-year toxicity. I'll talk about that in just a minute, but this was now looking at the primary outcome from this study. So just briefly going over the schema, eligibility was NCCN lower intermediate risk patients with prostate cancer or prostate cancer patients and histologically confirmed prostate cancer. This was an open label multi-center parallel group randomized controlled trial conducted at 35 centers. There were about 874 patients. In terms of the treatment arms, conventional fractionation was 78 gray and 39 fractions or 62 gray and 20 fractions. And then SBRT was 36.25 gray to the PTV and 5 fractions and 40 gray to the CTV. This was looked at daily versus every other day. And then you could see the PTV is listed there. And again, no androgen suppression was allowed on this study. In terms of the endpoints, primary outcome, it was non-inferiority study, biochemical or clinical failure. Secondary outcomes included overall and prostate cancer specific survival and acute and late physician graded and patient reported toxicities. So as I mentioned, the toxicity data has been presented or published before. So the first publication that I would like to highlight just briefly is one from Lancet Oncology in 2019. This was looking at acute toxicity, and the bottom line was that there was no significant differences in acute GI or GU toxicity between SBRT and conventionally fractionated treatment. And then this is the 2-year toxicity results that was just published in 2022 in the Lancet Oncology, and this is just highlighting by Dr. Tree, and this is just highlighting the differences between SBRT and conventional fractionation therapy by RTOG criteria. As you can see that, the blue line represents SBRT, whereas the red line represents conventional fractionation therapy. As you can see, there appears to be an increase or there's just more events, especially genitourinary events for the SBRT arm, but this was not statistically significant. for as per RTO geotoxicity. However, we again, as I emphasized before, we have to think about this in the context of patients and how patients feel. And sometimes physician grading may not accurately reflect, what really is going on, especially from a patient perspective. Just want to highlight this. So on the left-hand side, this is CTCAE graded, physician graded genitourinary toxicity, whereas on the right-hand side, it's patient-reported outcome toxicity. It's actually using EPIC 26. So you can see on the left-hand side, for example, I just highlighted in blue, at 24 months, it's looking really like there's no real significant difference between SBRT and conventional fractionation, and patients are doing quite well in terms of GU toxicity. However, on the right-hand side, this is the patient-reported outcome data, and you can see that there appears to be a bigger problem with regards to GU outcomes in the SBRT arm as compared to the conventionally fractionated arm. So, something that we need to await and we need to think about when we're considering SBRT or offering SBRT for our patients with prostate cancer, because even though the toxicity looks low, especially from a physician graded toxicity point, we need to wait for patient reported outcomes. So baseline characteristics, again, this is presented at ASTRO 2023. You can see the majority of patients had intermediate risk prostate cancer. Majority of patients had Gleason 3+4 disease. PSA tended to be less than 10, and you can see the breakdown of the T stages below. So this is the big reveal of the primary endpoint. So in terms of biochemical and clinical failure, with a median follow-up of 73.8 months, there was no significant difference. So basically, SBRT is non-inferior to conventionally fractionated radiation therapy. GU toxicity up to 5 years, we can see that there's no significant difference per RTOG grading for GU toxicity. And then you can see the trends for SBRT versus conventional fractionation. And then this is CTCAE GU toxicity, looking at grade 1, grade 2, and grade 3 respectively. And you can see in terms of grade 1, it's kind of all over the place, especially with SBRT, it's a little bit higher. And then grade 2, we can also see that SBRT there appears to be more events in the SBRT arm, and not so much of a big difference in terms of grade 3 or higher between the two arms. And overall, the events are low. We can actually see it's like extremely, extremely low. However, despite this, there's no significant difference between the two. So in conclusion, SBRT is non-inferior to conventional fractionation therapy for primary endpoint of biochemical clinical failure. Toxicity is really low. There were really low numbers of events. SBRT is very convenient. It's cost effective for both patients and for physicians and practices. And then just something to keep in mind when considering SBRT for prostate cancer patients in the context of these results, this is only applicable in patients not planned to receive ADT or pelvic radiation therapy. And of course, we're awaiting the patient-reported outcomes. So my take is that SBRT is considered a standard of care for patients with low or intermediate risk prostate cancer who are not planned to receive ADT, and I have no plan to treat their pelvis. But I do hesitate a bit about patients with significant upfront lower urinary tract symptoms. So I am awaiting some of those patient-reported outcomes, and I do want to kind of dig a little bit further into the toxicity data based on what I'm seeing thus far. All right, so we're going to shift gears a bit to go talk about post-op prostate. So here I'm going to highlight the Formula 509 trial. This was presented by Dr. Paul Nguyen at ASTRO 2023. So again, this is a post-op study. So eligibility included patients with PSA of 0.1 or higher after radical prostatectomy, and they had to have at least one unfavorable risk factor, and the risk factors are listed below, as you can see. Again, the design is a multi-center randomized trial. There was 345 patients enrolled. Treatment included either salvage radiation plus 6 months of GnRH agonist and bicalutamide versus salvage radiation plus 6 months GnRH agonist, abiraterone plus prednisone, and apalutamide. And patients were stratified by node positive, so PN positive versus PN negative, node negative patients, and then PSA greater than 0.5 versus PSAs that were 0.5 or less. The primary endpoint was progression-free survival with additional endpoints including metastasis-free survival, physician-reported toxicity, and patient-reported toxicity. So briefly, this is the patient population. So, you know, a lot of patients had Gleason 7 disease, and then fewer had followed by Gleason 8 to 10 disease. There are about almost 30% had node positive disease. The median PSA at time of treatment was 0.3. 75% of patients received pelvic nodal radiation, and the median radiation dose was 68.4 gray. And then this is just looking at the progression-free survival data at the median follow-up of 34 months. So on the left-hand side, this is demonstrating progression-free survival outcome in all patients. And as you can see, there is no significant difference between the two arms. So either with systemic intensification versus standard systemic therapy, there was no significant improvement. There's a trend towards an improvement, but this did not meet statistical significance. And then with patients with PSA, but specifically with the subgroup of patients with PSA greater than 0.5, we can see that there is a significant improvement in progression-free survival in favor of the systemic treatment escalation arm. And that was statistically significant. In terms of metastasis-free survival, again, very similarly, in the all patients cohort, we do not see a significant difference between the two arms. Again, there's a potential improvement with the systemic treatment escalation, but did not meet statistical significance. But in patients with PSA, presenting with a PSA of 0.5 or higher, we are seeing that the systemic treatment intensification does improve metastasis-free survival, and that is statistically significant. These are the metastasis-free survival results by the pre-planned stratified subgroups. So again, this is that improvement toward the systemic treatment intensification for PSA 0.5 or higher. And then this is the, interestingly, we are not seeing this in patients that present with node positive disease, so N1 disease. We are not seeing that. There appears to be, again, a trend favoring the treatment intensification, but this is not statistically significant. So in terms of talking about treatment intensification in the post-op setting, we have to think about the other post-op trial that also intensifies systemic therapy, and that's the Radicals HD trial. Of course, Radicals HD intensified systemic therapy differently. So basically, they extended the standard ADT from 6 months to 24 months, whereas Formula 509 kept the systemic therapy to 6 months, but intensified it by just adding more. So we can see between the two trials, in terms of metastasis-free survival for all patients, there was an improvement for all patients by extending the ADT to 24 months. Again, just reminding everyone that there was not a statistical improvement by basically adding more therapies just for 6 months, so shorter and harder, you can kind of think of. However, for the PSA 0.5 subgroup or 0.5 or higher subgroup, there was that statistically significant improvement in terms of metastasis-free survival for the patients that received shorter and harder therapy in Formula 509. And there was also an improvement in patients that had 24 months of ADT as well. So just, some takeaways here, for patients with higher risk features, intensifying 6 months of ADT may be an appealing alternative instead of lengthening ADT duration to 24 months. And this concept is going to be tested in the Prostate IQ study as listed below. And then just something else that we know, it's very interesting that the node positive patients did not see a benefit. So hopefully we'll learn more, especially from the NRG GU008 Innovate study. So if you have the study open, I encourage you to enroll to it, and we'll await the results. But essentially, the schema as is here, patients had to have pathologically node positive prostate cancer at the time of surgery. And then they were randomized to arm 1, which is radiation plus a GnRH agonist or antagonist for 2 years versus, which is similar to Radicals HD, or RT plus GnRH agonist antagonist plus apalutamide for 2 years. So we'll await the results from this. So in summary, this did not meet the pre-specified threshold for statistical significance for progression-free survival among all patients. However, the results suggest that intensification with abiraterone plus apalutamide improves metastasis-free and progression-free survival in patients with PSA greater than 0.5. Unclear why this wasn't the case for patients with node-positive disease. However, we could consider 6 months of ADT plus abiraterone plus apalutamide versus 24 months of ADT for patients with unfavorable features, including those with PSA of 0.5 or higher. So my take is, there's some caveats to the study. So there's no use of PSMA PET for staging, which is really being incorporated into the clinic and into the clinical setting in postoperative patients in whom we're considering postoperative or salvage radiation therapy. The other thing that I didn't mention here is that, it's really, we're seeing the benefit for patients that present with PSAs of 0.5 or higher. But in general, I think in practice, we're catching patients earlier with a PSA that's lower than 0.5. We're generally talking about starting and initiating salvage therapies or salvage therapy for patients with a PSA as early as 0.1 or 0.2. So, it's for a very unique population, probably maybe patients that have been lost to follow-up, or if they really have very aggressive disease, if they kind of show up and their initial post-op PSA is this high or like never went down, or they kind of come back for a test and then their PSA already is automatically higher than 0.5. So then we already know that they already have more aggressive disease than the average patient. So we need to really identify how to the appropriate patients for treatment intensification, potentially incorporate genomic classifiers to better personalize treatment. So I'm, kind of looking forward to that data in the future. Another question is, how should treatment be intensified? Do we want to go longer with the standard GnRH agonists, such as radicals HD, or shorter plus more drug? We do need longer follow-up from Formula 509. Could more intensified systemic treatment merely be delaying the METs? And then lastly, we need to think about the quality of life from the patient perspective and risks and toxicities with more treatment intensification, and just, what kind of short-term and long-term, what kind of a short-term and long-term impact these might have. And then finally, I just want to switch gears to non-prostate GU, specifically the Fast Track 2 trial, which is a trial in renal cell carcinoma. So this was presented by Professor Siva. And so we know that there has been a big push for the use of radiation for renal cell carcinoma. And there's just been a lot of data, very exciting data that have demonstrated the efficacy of radiation for RCC, specifically the use of SABR, or stereotactic ablative body radiation therapy, also known as SBRT, so SABR, SBRT, just depending on what you like to use. So this is very exciting data. This is one of the larger trials. This is the first multi-center phase 2 trial to investigate the efficacy of SABR in patients that are not surgical candidates for primary RCC. So briefly, again, this is the eligibility criteria in this treatment schema. So eligibility, patients had to have biopsy-confirmed primary RCC, a single lesion within the kidney. They had to be deemed medically inoperable or high risk for surgery, and there had to be a multidisciplinary decision made that active treatment was indeed warranted. Tumors were less than 10 cm, and they were not abutting the bowel, and the EGFR was greater than 30. This was a phase 2 multi-center trial of non-surgical therapy of primary RCC. Treatment consisted of either a single fraction or 3 fractions of treatment, depending on if the tumors were less than or equal to 4 cm or greater than 4 cm, and the prescription methodology is listed below. In terms of endpoints, the primary outcome was to evaluate local control after SABR, with the assumption that the local control at 1 year was 90%. And it was determined that a local control of 80% or lower would be considered not worthy of pursuing a randomized control trial further. So these are just the results of the Fast Track 2. So there were 70 patients enrolled, and about 56% had T1B RCC, and the median age was 77. In terms of the clinical outcomes listed on the right-hand side, median follow-up of 43 months, you can see that the local control rate was excellent, 100%. Freedom from distant failure, 99%. Cancer-specific survival, 100%. And you can see that there was very little in terms of kidney function loss. These outcomes are in line with outcomes that we see with radical nephrectomy or partial nephrectomy. So you can see local recurrence-free survival, either 100% or 99%. Metastasis-free survival 97 to 98%, cancer-specific survival 96 to 98%, or 96 and 98%, depending on radical or partial nephrectomy. And you can see the kidney function loss listed there. So essentially, what this trial has shown is that there's excellent efficacy and safety of SABR for primary RCC in patients who are inoperable. This should be a new standard of care for patients not eligible for surgery. And we need to evaluate, the next step is we need to evaluate this in patients who are operable. And ideally, we would like to do it'd be important to do a surgery versus SABR trial at some point in the future. So again, I just want to say thank you for this opportunity and happy 2024. I look forward to seeing what we'll learn about and what will be presented in this new year. Thank you.